To start our afternoon, it's my pleasure, my privilege, to kind of reintroduce our next speaker and also the chair of today's event, Dr. Jason Beaman. I hope you'll agree that through his guidance, we've been able to curate a pretty engaging program for you today. Dr. Beaman this afternoon will be speaking on psychostimulants. He's an associate clinical professor in the Department of Psychiatry and Behavioral Sciences, as well as serving as interim chair of the School of Forensics at Oklahoma State University Center for Health Sciences. Dr. Beaman completed his medical degree at the OSU Center for Health Sciences before kind of crossing town and completing a dual residency in family medicine and psychiatry at the University of Oklahoma, and then went on to a forensic fellowship at Case Western Reserve. Dr. Beaman is board certified in psychiatry, in family medicine, in forensic psychiatry, and in addiction medicine. Please help me welcome back to the podium Dr. Jason Beaman.
Okay, thank you, Sherry, and thank you guys for sticking through for the afternoon session. If you are a mental health provider or a primary care provider, you have had probably two things happen in the last 12 to 18 months. A, you've probably had a ton of patients showing up for ADHD. And then at the same time, your patients that have ADHD are calling you 18 times a day saying, I can't get Adderall. The pharmacy doesn't have it. We've run out. What do I do? And then you as a provider are now trying to send in prescriptions to pharmacies before they run out of it. And then you got to send it someplace else. And it's just turned into this weird kind of scenario. And so as we were putting this conference together, I thought it would be really good to delve into the concept of ADHD and maybe help answer the question of where has all the Adderall gone. Have you guys Googled it? Have you looked into why there's an Adderall shortage? If you had, you would find out that it's probably just one thing: overprescribing. That there's been a dramatic uptick in Adderall prescribing that now has caused a shortage. It's not like there's some weird chemical that there's a shortage of or anything like that. It's just a overprescribing or dramatic uptick in prescribing. So I have no disclosures or potential conflicts. We're going to talk about the evaluation of adult ADHD, and we're going to talk about the treatment of adult ADHD, and then going to tell you the appropriate use of psychostimulants. So this is a really, really busy chart, and I hate using busy charts, but it's got such great information. And this is psychostimulant prescriptions over time. So you see my pointers, there it is. So you see over here, you see the years. This is going to be males, and I'm going to show you females in a little bit. Here's the annual change in prescribing from 2016 until 2020, and then 2020 and 2021. And you see that there was some negative changes in the children. Okay, so prior to the pandemic, we had started to pull back on prescriptions for children, but even then we started to pull up on prescriptions for adults. And look at that, you've got 4% in the 30. The highest group was 35 to 39. And then after the pandemic, the highest group here is still 35 to 39, but a 14.7% change increase. That's incredible. So who's getting all the Adderall? Well, these people right here. And I'll tell you, and we're going to get into this, but I'll tell you that surprises me a lot, because ADHD in the DSM is a developmental disorder. It is a childhood disorder, right? And so then now it's like, well, if you had it as a child, then you can still have it as an adult. So it's those people. But that's not who we're talking about. That's not who it increased in, right? And so now there's this kind of concept of adult onset ADHD. And my professional term for that is nonsense, right? Nonsense. That's just like, I don't buy adult onset ADHD. We are told that ADHD is a brain disease, and you can actually go and look at studies that they've done in children showing differences in brains. And so how does your brain change when you are 35, right? And so we're going to go through some of the criteria. Now, I'm not saying ADHD doesn't exist in children, and I will tell you that there's some evidence, and I've seen this in my practice, of highly intelligent individuals that were not really challenged in their educational years, and then they get into a more strenuous environment like college or medical school, law school, something like that, and it really does unmask an ADHD type situation, and then you treat them for ADHD and they get back to their pre-stressful new situation functioning. But it's the people who, I've done great my whole life, now I'm 35, and I saw this TikTok video and I thought I should come talk to you. Probably should have talked to somebody else. Okay, and then let's look at females. Here you see average change also, and then much, much higher after the pandemic, okay? After the pandemic. And one of the things that has changed with the pandemic, and this is the answer, I'm giving it away up front. The answer to the question on where all the Adderall has gone is because of DEA regulations in prescribing controlled substances in reaction to the pandemic. So we all know this, that we were allowed to do virtual visits for all of our patients, which is a good thing. My 10-year plan at OSU when I was chair of psychiatry, it was we have to set up telemedicine. And it's going to take 10 years to do that. And then the pandemic showed me that I could do it in about 3 days, right? So I'm a big fan of delivering healthcare that way. But the problem is with controlled substances, you've got to be careful. And I think that we should stick to an in-person appointment for the first time, in person, for controlled substances, except for buprenorphine for the treatment of opioid use disorder, because we've got to get that out there. Yes, ma'am.
Where does psychology come into this? Really, truly diagnose that?
I am glad you asked, because I'm going to get into that. Yeah, the question is, where does psychometry or psychometric testing come into the diagnosis of ADHD? There have been some federal investigations into national companies like Cerebral. Maybe you've heard of that. But Cerebral is, take our online questionnaire, we'll send you Adderall. Okay, all right, I can click some boxes for you, right? And so now Cerebral is under investigation by the DEA for that exact type behavior. So then let's talk about how you diagnose ADHD in an adult, all right? And it actually involves all of these different steps, okay? It certainly is not, well, do you have trouble concentrating? Oh, well, here you go. Here's some Adderall. So starting with the initial assessment, when someone comes into me and says, I'm having trouble with attention, I'm having trouble concentrating, or I think I have ADHD, my very first question is, why now? What brings you in today, right? You have made it through your entire life. What's going on now? And is their history in agreement with the medical record? Well, I was on ADHD medications as a child, and then I stopped for a little while, and I'm starting to see some of those symptoms. Okay, good. Then I should be able to see you in the P&P getting those medications back then when you say, or I should be able to get your medical records, right? And if I start hearing things like, well, I don't really remember who the doctor was, even though I went every day for 18 years, I don't remember where was that guy? Who was that? that starts to raise some red flags and curiosities. Are they interested, and this goes back to Xanax also, are they interested in actually having a better life, or are they just interested in getting a pill from me, right? Are they just there? Are they driving the conversation towards Adderall? Or are they really interested? I'll do whatever you say. If you think therapy is what I need to do, then that's what I'll do. I'll take your advice. Okay, then my defenses go down a little bit more. But if they are like, I saw this medication on TikTok, I need that. Spoiler alert, TikTok's going to get beat up a little bit. All right. So symptoms of ADHD, we know what it is, but broadly in 3 categories of inattention, hyperactivity, and impulsivity. And in my clinic, the complaint that I get by far the most is inattention. So a lot of different ways to describe inattention. Trouble paying close attention to details or making seemingly careless mistakes at work or during other activities. Trouble sustaining attention for long periods of time, such as preparing reports, completing forms, or reviewing lengthy papers. Okay. Listening closely when spoken to. Trouble following instructions or finishing duties in the workplace. And what I would say is, because that's me, right? That's all of you. Are you telling me you've never made a grammatical error before? And the TikTok videos, and I actually follow these groups, not on TikTok because I'm too old for that, but for Facebook, which is more my age group, I follow these like ADHD support groups and whatnot just because I want to know what they're saying. And it's like, my boss yelled at me for being late to work today, but he doesn't understand I have ADHD. I'm like, that's not ADHD. You're late to work, right? And so there is a lot of, and we see this in psychiatry more than anything else, pathologizing normal human experience, okay? So when we list these symptoms and you're like, I couldn't find my keys, or my wife, and I get this all the time, my wife says I don't listen to her. It's not ADHD, all right? Listen to your wife. And don't tell my wife I said that. All right. Other symptoms of inattention, like organizing tasks and activities or managing time. Engaging in tasks that require sustained attention. Losing things such as your keys, your wallets, or phones. And being easily distracted by unrelated thoughts or stimuli. Being forgetful in your daily activities such as paying bills, keeping appointments, or returning calls. And then hyperactivity and impulsivity. Sorry, this is small font. Experiencing extreme restlessness, trouble sitting still for extended periods, or wearing others out with your activity. Fidgeting or hand tapping. Boy, I did that as a kid. My mom will definitely attest to that. Being unable to engage quietly in leisure activities. Talking excessively, answering questions before they are asked completely, having difficulty waiting one's turn, such as waiting in line, and interrupting or intruding on others. Okay. So I'm going to get into it a little bit more, but the hallmark of that is that as a group right now, all of us have some of those symptoms at different times and whatnot. ADHD is where you are outside of the group, right? That you are outside of what the standard experience is, and that it's causing some sort of dysfunction in your life, right? It has to cause some sort of dysfunction. Now, when you're evaluating these individuals, the medical examination can be important because there's other conditions that could cause it. And trouble paying attention absolutely could be thyroid disorder, right? Could be hyperactive thyroid. And so you feel jazzed up, you're not able to sit still, your mind might be racing. Or it could actually be low thyroid, where you have symptoms like depression, and we know that trouble concentrating is one of the 9 symptoms of depression. So it could be also major depressive disorder, right? Could be bipolar disorder. And I have seen that more than once in my practice. Someone comes in saying, I can't sit still, I can't complete my projects. Okay, well, what kind of projects? Oh, well, let me tell you. I am writing the world's greatest novel. At the same time, I am, developing the best algorithm for stock trading. And I'm like, okay, well, you're doing a lot of stuff. When are you trying to do this? 3 a.m., at the same time, I decided to redo my wood floors. I've never done that before. It's harder than it looks. I tore up the floor, but I couldn't get it back together. So it's like, okay, now I'm starting to worry that maybe you have bipolar disorder. And I've seen many individuals with mania actually diagnosed with ADHD. And the worst thing you could do to someone who's manic is to give them a stimulant, right? It is literally, well, figuratively pouring gasoline onto the fire. And you're going to make it worse. You're going to make it worse. And then also anemia. Because if you're anemic, you're going to have a lot of lack of energy. You could have trouble focusing. You could have fatigue. So it could be some sort of medical problem that's causing anemia. Substances, okay. Hopefully you're getting hearing a theme today from the psychiatrist that we're not a big fan of substances, both controlled and not controlled. And a lot of the symptoms that I see in my practice absolutely can be better explained by substance use. So anything, any depressant can impair your attention, right? So if someone's on opioids or benzos or whatnot, then that can definitely cause concentration problems. Stimulants in certain conditions. Okay, and I got to say that because stimulants are the recommended treatment for ADHD, so how can they cause symptoms of it? It's a lot. Okay, if you're giving someone a lot of a stimulant, they're going to be revved up to the point where they're not focusing. Okay, so for example, methamphetamine. If you were to take methamphetamine, you would probably have the cleanest, most organized house today. By tomorrow, it's going to look like bears on unicycles, right? Like, it's just going to be, because there's a point where it really does hit the dopamine right at that perfect point, but then you go over the edge and it's too much. I've recently been involved in 2 different homicide cases in Oklahoma that are related to medical prescribing of Adderall, and in both of these cases, the amount of Adderall was just absolutely incredible. And so I highly, highly, highly recommend you don't go above FDA recommended limits or guidelines, because these are dangerous medicines. And you may be cutting off your nose to spite your face. It's like, well, you're not paying attention. We'll give you more and more and more, which doubles down and makes the problem even worse. And then marijuana, I think I hit on this a little bit later. That is an absolute no-go for me. All right, we can talk about marijuana with antidepressants and opioids, should you continue both, and there's a lot of gray area with that and a lot of arguments on both sides. There's little to no argument for treating someone for ADHD if they're taking marijuana. Okay, I'm not saying that you can't have ADHD if you're on marijuana. I'm saying stop the marijuana and we can talk. Okay, but I'm not even going to engage a conversation of trying to treat the side effects of the substance when it's well documented. Even the pro-marijuana individuals will not argue that it doesn't cause some sort of cognitive dysfunction. So in our clinic, it's a no-go. We will not treat you for ADHD with the stimulant if you're using marijuana. Psychological evaluation, so this is to answer your question, may include instruments and assessments. And really, we are looking at your cognitive ability, your attention, and then your executive function. And you know, when you refer a patient to a psychologist or a neuropsychologist or a school psychologist for testing, you shouldn't really specify what testing you want. Okay, what you're saying is, I want you and your expertise to evaluate this individual with the tests that you think are appropriate, right? And so it can be very, very, very helpful. Also, a little bit of advice, it can serve as a gatekeeper for everyone wanting Adderall. Well, if you really have ADHD, let's have you test it. The caveat is, and we've got in our clinic a school psychologist, we've got a neuropsychologist and psychologist, their wait list is 8 to 12 months long, right? And now I'm hearing in children that insurance companies are not paying for ADHD testing. I don't know if you guys have heard this yet, but you're probably going to start experiencing that. They are trying to say that it needs to be tested through the school first. Well, the schools don't have all the capacity to do all this testing. So I'm a huge fan in formal psychological assessment, not a screening instrument, but an assessment measuring your cognitive abilities, because maybe it's not ADHD, maybe it's something else, and the testing will say, actually it's your memory. Your memory is the big problem. Your attention is fine. The deficit's in the memory, and so psychological testing can really help demonstrate that. But with that being said, there are all sorts of rating scales out there, and I feel obligated to run through them with you, starting with the childhood symptom scale. This is retrospective assessment of the different 18 DSM-4 criteria. You may not know, but now we're in the DSM-5 TR. So it will go up by a number. 10 years later, we'll do the text revision, the TR, and then 10 years later, we're probably going to have the new DSM-6. So we just last year hit DSM-5 TR. So this is DSM-4, which was like 1990 when it came out. It asks them retrospectively, as a child, did you have this? And also looks for functional disabilities, oppositional defiant disorder, and conduct disorder. The Windner Utah Rating Scale is also a retrospective assessment of symptoms from 8 to 10. And there's two different versions. There's a regular version, 61 questions, which does seem excessive, especially for someone who may have ADHD. So they came up with a short version with 25 questions. The Adult ADHD Rating Scale 4 has a long version and a quick screen to determine if they even warrant using the long version. Was originally designed for children and adolescents, but they have adopted it successfully in adults. You have the Brown Attention Deficit Disorder Rating Scale in diagnostic form, clinical history, which is important, early schooling, which is also important, family history, physical health, substance use, and sleep. And sleep has got to be at the top of your radar for these individuals, because if you're not sleeping for whatever reason, you're going to have trouble focusing, okay? But two, there are certain conditions like sleep apnea that manifest as trouble paying attention, right? And if I'm not sleeping, I can't find my keys and I can't find my wallet and all that stuff. So I think you need a really good sleep assessment to find out to what degree that may be contributing to the symptoms. This instrument is also going to gather data from the observer and significant other, which is also really, really important because you don't want to just rely on one data source. And, I take this approach to medicine that we are like Hippocrates 2,000 years ago. People would seek him out because they had some sort of ailment that they wanted help for. And we are healers, we are helpers, and people come to us for help. They don't come to us to lie to us. So I don't inherently think everyone's trying to pull one over on me. I take this approach that my default position is my patients are coming to me for help and they're telling me the truth. And I'm going to maintain that position until I have reason to think otherwise. Okay? With that being said, you have to have your radar up on these individuals for a couple of reasons. One, maybe they're trying to get pills to sell because Adderall's got good street value right now. Really good street value. If you're in the Adderall game, you're making a lot of money because of the shortage and because of the uptick in just overall drug use. Good time to be selling illegal Adderall, but also don't do that. Okay? And then the other thing is they may be looking to get high. Right? It's an abusable substance. You can snort it, you can inject it. They may be looking to get high, and so you want to. You're the gatekeeper. You gotta protect against that. Also, they may think they have ADHD, legitimately think they have ADHD, and they're coming to you for help. And it's your job to be the gatekeeper and see, do they have it? Do they not have it? But not just to say, well, you're answering all the right questions, so here you go. You are the gatekeeper, and remember, first do no harm. Giving someone who doesn't have this legitimate diagnosis a controlled substance, that would be doing harm. That would be doing harm. As I said, they might kill someone, so be careful. The Conners Adult ADHD rating scales, this is one of the more commonly used ones. It's got a screening, a short form, and a long form. Also includes self and observer reports. It has 8 different scales that can give you an idea of what's going on. It allows for ADHD measured by DSM-4 criteria by looking for emotional lability. It has good inter-rater reliability between self-report and physician rating. Okay, so tell me what you're experiencing. Okay, well, I'm going to put it in this checkbox. And then the patient does their own and they put it in good inter-rater reliability between the two. Current symptom scale by Barkley and Murphy is self-reported of the 18 symptoms corresponding to the DSM criteria. And then the Wedner Adult Attention Disorder Scale, Wedner Utah, this is the Wedner-Reimer, measures severity of symptoms using Utah criteria, and it's helpful to assess mood lability, which is either depressed mood or mania, so mood lability symptoms. So the instruments can be really helpful and give you some sort of objective measurement, but it is still relying on the patient's self-report. And that's going to be kind of a theme here, is you have to do something to not rely solely on the patient's subjective experience. You got to quantify it in some way. Collateral information is super helpful, and it can be helpful to have it from the person who has that information, the spouse, a roommate, or whatever. But not just ask them, hey, do you think they got trouble paying attention? Oh yeah, they're always losing things and whatnot. I like to ask specific criteria. So I'm going to evaluate the patient by themselves, ask them to wait in the waiting room, and I'll bring the spouse back and tell the spouse, so the patient, I'm going to say, tell me how this manifests the most. Well, I just can't pay attention any of the time. That's too vague. I want you to tell me something you could not pay attention to. Well, reading the Sunday newspaper. I just can't make it through. Okay, there we go. And then I'm going to bring the spouse back and I'm going to say, how does this manifest the most to you? What do you notice the most? And then I'm going to go gradually back into the newspaper and ask the spouse, well, anything that they've told you they can't do? Yeah, he's just always complaining about not being able to finish the newspaper. Really wants to. He's like set a schedule for it. He's done this, but he hasn't been able. Okay, well, that's validating information. If I don't get that, then I'll eventually get in and back up to it and say, well, is he able to finish the newspaper, the Sunday newspaper? What? We don't read newspapers. We don't even have a subscription. I haven't seen that man read a newspaper since I met him. Right? And well, okay, now I'm worried. So getting that collateral information, separating them, validating them can be very helpful. Again, very important to ask for those specific metrics. And if you're still getting a lot of vague stuff, then ask the patient and the spouse to keep track. When you look at the criteria, you got to take the symptoms and determine whether or not they meet criteria. Now, trouble concentrating. That symptom is in at least 3 different DSM diagnoses, right? Depression, anxiety, and ADHD. Are you going to diagnose them with those 3 conditions because they told you they had trouble concentrating? Okay? You have to decide, and you can put that one symptom in one single bucket, okay? Or you're just going to end up with giving them the DSM. Okay, here's your discharge diagnosis, right? You have to assign it to one bucket. So which condition do you think their trouble concentrating fits the most, okay? For example, I can't focus. I have trouble concentrating. Well, when did that start? Well, 6 weeks ago after my mom died. Okay, well, that's probably related to depression or a grief-related thing. When did that start? Well, I've never had the ability to focus, and even when I was a child, I had trouble paying attention. Okay, well, I may put trouble concentrating into the ADHD bucket there. So you have to decide, but I'm not going to say, well, you trouble concentrating, ADHD, depression, anxiety. You're just going to overdiagnose people. Now, again, talking about adult ADHD. ADHD is a disorder that begins in childhood. The DSM specifies that they have to have symptoms prior to the age of 12. Okay? Prior to the age of 12. Symptoms. Now, to me, that's super vague. All right? Because everyone's going to say, yeah, sure, I had that. And you know that I am a huge skeptic of pharmaceutical companies. We also know, by the way, the uptick that we've seen in prescribing, just purely coincidental, I'm sure, coincides with the patent extension for Adderall XR, right? That when the patent ran out on Adderall, manufacturers came in at the last minute after they squeezed every dollar out of Adderall and came out with Adderall XR, and that's when you saw a dramatic push for adult ADHD because they tried to get that indication to extend the patent, right? So there's a lot of shenanigans in psychostimulant prescribing, and the pharmaceutical companies were actually starting a whole group of studies looking to demonstrate this. So we go back to the DSM. We already know the DSM is manufactured by the American Psychiatric Association. Those are my people, and we know that they have been influenced by pharmaceutical companies. What's my evidence for that? First of all, go to the American Psychiatric Conference, and it looks like a NASCAR, right? They have got banners and product labeling everywhere. But with the criteria for addiction specifically, there are 11 criteria for addiction. Criteria 10 and 11 is withdrawal and tolerance. And then there's an asterisk. And the DSM says that if they have withdrawal or tolerance to any substance, but they're taking it as prescribed, then we don't use that as criteria for addiction. So if you're getting Adderall from your doctor and you have withdrawal or dependence, not addicted. If you get it from your friend, you're addicted. That doesn't sound like science to me. Like something magic is happening in your brain, depending on where you're getting it, that it's not. So, and we know through opioid litigation that the pharmaceutical companies influence the APA to put that asterisk in there. So when I see must have symptoms, really what I want to look for is a diagnosis. Okay, that this was such a problem for you as a child that it manifested as a child. Again, I personally give a little bit of leeway for those college students that are in that new situation or medical students, law students or something that are in this new, maybe someone just graduated college and they're in this new job and it's starting to uncover. In that transition period, I'll give a little bit of leeway. But if you've been doing your job for 35 years and now all of a sudden you've got ADHD symptoms, I am highly skeptical and not likely to prescribe a controlled substance. The DSM also says you got to have 5 symptoms, so it's not just trouble paying attention. The problem is when these patients come in and you say, do you have this? Yes. Do you have that? Yes. Do you have this? Yes. Okay. You're going to answer yes to everything. And the big kicker is must be present in two environments. Okay, it can't just be at school. It can't just be at home. And so I will ask, I don't ask them, well, does it exist in multiple environments? I ask them, where do you have symptoms at? And tell me. Okay, so it's at work. Do you have any problems anyplace else? I'm not going to tell them that they have to have it in 2 places. I want them to volunteer to me that it's in 2 places. So has to be present in 2 or more settings, home, work, and whatnot. Now, your differential diagnosis, obviously other mental conditions. We've already talked about depression. You heard about anxiety from Dr. Gill, and trouble focusing and concentrating is a criteria for generalized anxiety disorder. So maybe that's what it is. Then PTSD. Trouble focusing is one of the symptoms of PTSD, and it can manifest in a couple of different ways. One is individuals with PTSD have alterations in the way they view the world, right? That all of a sudden, like I was mugged, and now I think that there's a mugger around every corner, and I'm just worried about that, and I think the world is a dangerous place, and so my mind is drifting towards dangerous places. Or it could be drifting towards the incident itself. I'm going back to combat, or I'm going back to my childhood sexual abuse, and I can't get it out of my mind. So it could be flashbacks, a number of ways that it could be coming from PTSD. Also, personality disorder. And if I had to describe borderline personality disorder in one sentence, it would be a rapid rise in emotions, okay? A rapid, not even rise, a rapid shift in emotions. You and I are getting along just fine right now. I say something and all of a sudden it's like plates against the wall. Like, whoa, chill out. Where did that happen? And if you are living in a world where your emotions can go from 0 to 60 just like that, you're going to have trouble focusing, right? You're going to have such incredible release of hormones and cortisol and whatnot that it's going to manifest as trouble sleeping or trouble focusing, trouble paying attention. There are medical conditions that we've already talked about, whatnot, and then again, you have to be aware of in this current environment about malingering or nefarious causes, trying to get the medicine from you for whatever reason. Well, what is your treatment plan? And you start with, what is the patient's goal? Well, I want straight A's. Okay, I don't have a straight A pill, all right? I don't. If I did, I'd be a billionaire right now. So whatever their goal is, it should be measurable. I want to be able to read my textbook for 20 minutes in a row. I think that's reasonable, okay? I think that's reasonable. Now, if I want to be able to read my textbook for 5 hours, okay, that's a lot of Red Bull and a little bit of Mountain Dew with it. Not going to happen. What is the patient's past history, right? Because do they have a history of, let's say that they've got psychological testing, they've got all the symptoms, they are fidgeting in the evaluation, everything 100% sure this person has ADHD, but they also have a history of selling their pills, okay? You may just have to live with, less ideal treatment because I will not, if I know that you've sold pills in the past, I'm not going to give you pills, okay? I can't do that. you should absolutely use a controlled substance contract. And this case, I gave 8 hours of DEA training yesterday, so I'll take a little second and tell you guys about that. If you're not aware, the DEA has recently mandated that you're going to have one time in your life 8 hours of training to maintain your license. And maybe you've had it, maybe you haven't, but and you need that when you renew your license, your DEA. So for some of you, it's tomorrow. For some of you, it's 3 years from now. We're partnering with St. Francis and with the Osteopathic Founders Foundation to offer that education to you. We are having a training tomorrow. So I get to do back-to-back days at the conference center. And so just be aware of that. If you're interested in that training, you can go to the Founders Foundation website to find out the dates. Lots of flexibility as far as virtual and evening, lunch, and whatnot, but we're trying to provide that education to you. As I was providing that education yesterday, I had some pediatricians in the audience, and they asked, should we be using controlled substances for our kids? And should we be doing urine drug screens for our kids with ADHD? And the answer is absolutely you should. I've had at least 2 patients in my former life family medicine practice who their parents were taking their pills, and so the kid tested negative. So absolutely you should. And there's no reason not to do a controlled substance contract. All right, it's a controlled substance, nothing magical about giving it to a kid. You want mom to know the rules of the game. And that is important. So absolutely you should be doing that if you have kids on ADHD medications. And then your treatment plan has to include monitoring for diversion. Has to. This is a highly addictive, diverted medication. We're going to talk about what that monitoring looks like. Okay, let's go through some treatment options, but I can't tell you about treatment without giving you Beaman's rules for medicine in general. As a general rule, patients should not die because they went to the doctor. Okay, I think we could all agree with that. And if you've heard my opioid talk, you know that that hasn't always been true. Also, patients should not get addicted and then have lifelong dysfunction because they went to the doctor. Patients should get better and feel better because they come to see us. All right, with that little caveat, let's talk about stimulants, including let's go through the different options. So with the amphetamines, you've got extended release Adderall, you've got a longer acting amphetamine type metabolite with Vyvanse, and then you've got the immediate releases. With methylphenidate, you've got immediate and extended release. And then you have non-stimulants, such as Strattera, and relatively new on the market is Intuitive, which is guanfacine. We've used that for a long time in children, and now it's approved for adults. Antidepressants, including bupropion, and that's my gold standard, that's my first line, that's my go-to, right? If you're an adult having trouble focusing, I'm going to give you Wellbutrin. It is a dopamine receptor agonist, hits that dopamine receptor. It's also SNRI, selective norepinephrine reuptake inhibitor, and helps with concentration. And my patients with depression love it because it helps with their focus also. This is a good alternative to find out what kind of person you're dealing with here. You say, you know what, there's actually a medication that is non-addicting and really, really has been shown to help with ADHD. It's called, maybe you've heard of it, it's called bupropion, or trade name Wellbutrin. I'd like to give that a try. And if they say, no, I want that thing I saw on TikTok, what is that? Adderall, is that the word? And if they say that, then it's like, okay, this person's just here for the medication, and they're not really interested in getting better. I have no qualms putting an adult on bupropion for trouble focusing. And then also you can use TCA. Despermine is probably the one that is most recommended. Some strategies on whatever you choose. I highly recommend you go to non-controlled first. but you want to start at a low dose and try titrate monthly to functionality. And what is functionality? Because they're going to come in for a follow-up visit. You don't want to say, well, how you doing? I'm still not there. Well, I don't know what that means, because I don't know if their expectations for the medication matches mine. So I'm going to say, okay, tell me how long you read the newspaper this week. Okay, and if they're like, not at all, like no improvement at all, then I'm going to be a little bit curious, because most people will find an improvement, right? If I give you a Red Bull right now and measure your newspaper reading time before and after, it's going to be more, right? It's going to be more. These things just naturally help everyone focus, whether you have ADHD or not. So if you're coming in and saying, I've had no benefit at all, I'm a little curious, not in a good way. All right. Remember that all medications are risk-benefit analysis, okay? That's your, do I use the medicine or not? Do you think, in your own opinion, that the benefits are worth the risk, okay? And there may be more benefit based on occupation. I will tell you also that I have a rule about being unemployed and getting a stimulant. Okay, that's just kind of my own personal rule. It's not hard and fast, but you know, this is supposed to improve functionality. What is it that you're trying to function with, right? And I think that if you're unemployed, then the risk of the medication outweigh any potential benefit. Okay, so, and I'm not picking on people who don't work outside of the home. If your career is to maintain the house, that's important, and that we've seen a lot of ADHD with that. But if you're like, no, I don't have any kids, I'm not married, I just sit at home, and it's like, well, what do you need the medicine for? Okay, I have trouble focusing. It's like, oh, okay, maybe just try to help with that. To get some bupropion or try focusing harder or something, but like, I'm not going to give you a pill. And there may be more risk based on their background. If they've ever had an addiction, I would not give that individual an addictive substance. The risk-benefit equation constantly changes. At every visit, you need to get new information. You may have more benefit, you may have more risk. So you need to monitor, and again, always check function. And so let's go through monitoring really quick. Starting with drug testing, you know that drug testing is immunoassays, which is screening, has a lot of false positives. Zoloft will test positive for amphetamines, pseudoephedrine will, whatnot, so be aware of that. Mass spectroscopy is confirmatory. Mass spec doesn't lie. Okay, if it's in the mass spec, they took it. Urine drug screen should be done at the visit. It should be done frequently at the beginning of treatment, and then you can space it out to 6 months to a year. After that, all patients are tested the same. Okay, I have my own biases that if you come in and you've got facial tattoos all the way down, then I'm probably going to inherently want to drug test you more than the 80-year-old grandma. But my own experience has been I've been lied to more by the 80-year-old grandma, okay? So now I don't even worry. I'm not trying to catch people lying around. Everybody gets tested the same. I'm a board-certified forensic psychiatrist. I have specialized training in lie detection, and I can't test any better than you guys can. Test everybody. Abnormal urine drug screens can be either positive for something it should not be and negative for something it shouldn't. And when you have an inconsistent positive, what I want you to do is acknowledge that in the chart and do something. I don't care what you do, but I want you to do something. If you say urine drug screen reviewed, no concerns, or positive, refilled their medication, if I get your chart in a review, which I do for the DEA, I'm going to say that was bad medicine. You should not have done that. If you said going to do more frequent monitoring, then I have no problem with that. Ask yourself if the substance is contributing to the symptoms, what the substance is. If they're positive for marijuana, is that an explanation for their symptoms? And then at all times, are you abiding by the Hippocratic Oath of doing no harm? Things you can do is more frequent monitoring, discontinue the medication, or refer to addiction treatment. Inconsistent negatives are huge red flags, and you should immediately consider cessation, right? The medicine you're giving them is not in their body. Where's it at? It's on the street. And you can never, ever, ever knowingly contribute to diversion, okay? So huge red flag. Check the P&P. I think the P&P should be checked every time you give a prescription. No matter how often the state tells you have to check it, you should check it at every time because it's information that would change your outcome. No reason not to check it. Pill counts are good to verify that they're not taking more than prescribed. You can have them come into your office, or if they live far away, you can ask them to go to the local pharmacy, and then you call the pharmacy. You look up, the Walmart in Broken Bow, call the pharmacist and say, hey, did Miss Smith bring her pills in? Were you able to count them? Aberrant behaviors are huge red flags that you would lower your propensity to give them a controlled substance, and they are listed there. Again, with marijuana, absolute no, not even a discussion. And for me, it's like the easiest thing, okay. And we tell you up front that if you ever test positive for marijuana, we're gonna discontinue the medication. So it's, to me, not even a discussion. All right, in conclusion, ADHD requires an accurate, objective diagnosis. Stimulants should not be first line and should be used very cautiously, and documentation and monitoring are paramount to avoid patient harm and physician liability. All right, with that, I am happy to answer any questions. Questions? Yes, ma'am.
So if some of your patients are taking the stimulants and they say, I take breaks, or I work on shift schedule, so I'm only taking on my shift 3 days a week, do you see sometimes negative urine drug screens in that kind of scenario?
Yes, that's true. If they're not taking it daily, you may have a negative urine drug screen. What I would do is do random testing and ask them when they did it last or whatnot. Also, though, in those individuals that tell me, well, I only take it a few times a month, well, guess what? You're only getting a few pills. And I'm not giving you 30 if you're not taking it 30 times a day. And then if they tell you that they've done that in the past and their prescriber retired, check the P&P and say, well, why were you getting it early, right? That's a good strategy. Yes, sir.
I feel like I often go really guilty because when I do the urine tests, the insurance doesn't want to cover it. Is there a certain way that it's more likely to be covered?
Insurance should cover the screening exam for every controlled substance at every visit. It's a very cheap, inexpensive test. If you're getting pushback, you may be ordering it in a way that is getting like reflex, confirmatory testing, or something like that. But like the test strips for urine, I mean, they're not very expensive. So, and it's by every guideline to do urine drug tests for anyone getting a controlled substance. And I haven't heard of companies pushing back. I have heard of a lot of companies pushing back on confirmatory testing, especially if it's the doctor that owns the lab, right? Because they're getting confirmatory testing on every single patient every single time. Blue Cross Blue Shield does not like that. Yeah, good question. Other questions? Yes, ma'am.
What would you say would be your ratio of the textbook adults or people coming in, reading verbatim from DSM or what they Googled about these symptoms versus what it really is? Because when I work with adults, I have to weed out a lot of that.
Yeah, that's a good question. I am very skeptical of ADHD in adult and also in children. I think it exists in children, but I think it's incredibly overdiagnosed. And back in family medicine, when I treated children, the mom who brought them in was like, okay, there's your problem, right? I'm like, oh. Okay, maybe give you some sort of pill. And I see a ton of wanting to pathologize normal behavior. So I don't know that I'm the right person to ask that question to, because I am largely skeptical. And people will say, I benefit from Adderall. We all benefit from Adderall, right? Like, who would not benefit from Adderall or a little bit of methamphetamine, right? doesn't mean that I have that brain structural problem. And I think over the next decade, you're going to see a lot more evidence coming out supporting more clear criteria on ADHD. Okay. Sir?
Where can you get the psychometric testing for ADHD?
Yeah, the best person to test for ADHD would be a school psychologist. They are the ones doing this day in and day out in adults and children. Also, a neuropsychologist can do it. There are not a lot of them. We have both at our clinic at OSU Behavioral Medicine. I think St. Francis, Dr. Hansen does a lot with St. Francis. I don't know if he works for St. Francis, but there are some people out there in the community, but you're going to wait a very long time. Yeah. Sir? Do you have a favorite one for adults that you do primary care? Favorite tester? Oh, of the questionnaires? Like I think I've seen the most evidence on the adult rating scale 4. Yeah. Yes, ma'am.
Is there any truth to, I heard recently, the notion that children who are not treated and have true ADHD have increased risk of developing drug addiction later on?
Yeah, so that's a great question. The question is, a lot of studies coming out now or implication that if we don't treat it as a child, they end up with drug addiction as an adult. I will tell you, I have heard untreated ADHD leads to addiction as an adult. Use of Adderall as a child leads to addiction as an adult, right? I think that whatever is causing those symptoms also manifests as addiction and criminal type behavior as an adult. So very skeptical on all that, but there's evidence going all the different ways. Yes?
Another question. Related to well-being, when you're talking about it being the best, probably the best antidepressant, with its effects on dopamine, say you have a patient that's also on an antipsychotic that maybe has a schizophrenia diagnosis, would you then have a conflict because you have...
Yeah, not necessarily. And I want to be clear, it's best medication for adult ADHD, not best antidepressant. They're all equally effective for depression. Okay, so there is a huge trend recently to abuse your Wellbutrin. And in my forensic world, I did have a guy who stored up 10 days worth of pills, crushed them, snorted them, and then I want a little crime spree. Don't do that and tell your patients not to do that. You can become psychotic on Wellbutrin, but not at a therapeutic dose. And it wouldn't be my first line in someone with schizophrenia, but I have used it in people with schizophrenia. And I just don't think it hits dopamine enough to cause that kind of problem at a therapeutic dose. Yes, ma'am.
We've had patients who have talked about their post-COVID flaws.
Yeah. Yeah, so COVID brain fog and long haul COVID where inattention and trouble focusing is one of those things. What we're talking about today is this concept of adult ADHD. Stimulants have a role, like elderly people who have a lot of inertia with their depression. I use Adderall with them. People whose depression, not even just elderly, but it's in the guidelines as an adjunct treatment for depression. Adderall has benefits for sure, and so I think you as the prescriber need to decide risk benefit. I may be less hesitant for a short-term trial in long-haul COVID with Adderall because there I feel like, believe it or not, I know a little bit more about what I'm treating. Right? You had this virus, now you have some sort of post-viral syndrome. Yeah, let's give you 6 months of Adderall until you can get through that and whatnot. I would have clear expectations that after 6 months, or no matter what, we're probably not going to continue this. You don't want to be the long-haul COVID Adderall prescriber. You'll be very busy. Be very busy. Yes, ma'am. Well, I mean, we're We're talking to them here. And we teach all of our medical students to adhere to the DSM criteria, right? I will tell you, I think the biggest trend with ADHD in primary care has been to not treat it. And I know a lot of prescribers who are like, you know what? I'm just not even going to treat it. I'll refer you to psychiatry and you can get it there. I think what needs to happen is that we need better objective measurement of the diagnosis. But I think family medicine is more frustrated than anyone about the uptake. Yeah.
I just make a, when we talk about benzodiazepines before and now, amphetamines. So I think we need a new diagnosis because most of us are dealing with legacy prescribing.
Yep.
These people are walking in, they've been on it, you can check the DMP, they've been on it. And so, how do you deal with this legacy?
Yeah, so legacy in benzos is a lot different than legacy in stimulants. I have less concern titrating down even more rapidly stimulants. I have seen lives turned upside down from losing a benzodiazepine prescription. I'm telling you, the psychological withdrawal from a benzo lasts for about 2 years of just this incredible, overwhelming anxiety and racing thoughts and all that. Stimulants, not so much, right? Stimulant withdrawal is probably total going to last 3 to 4 weeks, but most of that's going to be in the first week. And it's not a pleasant withdrawal, but it's not miserable. It's not opioid withdrawal. It's not. So I have less concern about that. And at that point, it becomes, I'm not going to hurt the patient by stopping it. And if in my medical judgment, I wouldn't prescribe this otherwise, yeah, I would do that.